I'm so sorry for having to have you all turn your necks this direction, but we're going to get through it. We don't have much further. We're just going to talk about some sinuses and some orbits and wrap this chapter up. We'll see if I can find Joe. Let's see how much time we have. Okay, so the essential projections for our sinus.
I sent it to 17 and days 17 and 19.
For sinuses, we're going to go over the lateral, the Caldwell, which is going to be done a little different than the Caldwells you're used to, the Waters method, the open mouth Waters, and then the SMB. These should look very familiar because we went over all the previous areas of the skull and face. But there are some slight variances on these when we talk about the sinuses to make sure you make note of. Now, what have I said about sinuses a lot to y'all? The registry loves sinuses. They're asking you a lot of questions on sinuses. Why? They're the most common done head work that we still see come in quite regularly, especially during your allergy seasons. So make sure, I would say, big gold star on all 5 of these positions, and everything about sinuses period is just a big giant gold star. So make sure that you're making note of and remembering. Now, one thing, if you want to go ahead and write in your notes for all these positions, what's the main characteristic of sinuses that I said we must always do? They're always going to be upright. And what is the reason behind that? Those air fluid levels, exactly right. If we're laying down prone or supine, those air fluid levels are not going to manifest correctly on the x-ray. We have to, under every circumstance, no matter what, without exception, do upright x-rays. I didn't get tongue-tied one time during my speeches. I'm proud of myself. That was pretty smooth. Wish I get tongue-tied at least once.
I think Amma did.
She was really nervous. She did good though. I was proud of her.
Was that tongue-tied or when she misspoke? She said
about racism
instead of narcissism.
I guess that made her nervous.
Poor thing. She was
nervous.
so embarrassed. But I said everyone got a good laugh out. It's all right. That's what you call Freudian slip. Happens to the best of us.
I'm glad they weren't upset.
No, everyone thought it was funny. All right, so like I said, guys, upright position, mega gold star, is absolutely necessary to demonstrate those fluid levels. Situation should always remain, as we say, horizontal because we're doing these upright positions. We're going to make sure that we collimate really tightly on our sinus x-rays. And as I always say, we're not leaving it open. We're not leaving it wide open, especially on sinuses. If we do, those sinus cavities are going to begin to fade away. They're going to get obscure. We're not going to see them in that high quality detail that we want to see for those distinct sinus cavities. And then, I've never seen anyone do this, but it's kind of like, remember with the acute abdomen x-rays we talked about way back in the day, first semester, you're supposed to have the patient lay on their side for 5 minutes before you take an exposure to allow the fluid levels to settle. Same concept for sinuses, although no one's actually going to do this, let's be real. Yeah, it's not happening, not happening. But they do recommend that you take several minutes to allow the sinus levels to settle before you make an exposure, because they claim that's going to give you a better demonstration of those sinus fluid levels. Me personally, I haven't seen a difference. Maybe it's because I've done mostly kids, but they seem to settle right away when I've done these sinus x-rays on kids. But that is a recommendation by the book, something to make note of.
Was it hard to keep a child like this?
Oh, you have no idea.
What would you do?
They just have to force their head in that position and clamp down, like hold it just really tight. Really, really tight.
So you would always wear that protection on.
Oh yeah, you have to hold a lot of patients. You have to hold almost every patient with pediatrics. At least at TCH you do. We don't use pigostats.
Damn.
Let's see it. Question.
Speaking of sinuses, sounds like we all have some sinus problems. I know mine are messed up. Every time I go to North Texas, I get really congested. No matter what time of year. Something in the air up there just wrecks my face.
Like that?
Just like that.
So child.
We don't name names. We don't name names.
All right, so lateral projection. You're going to see this on every one. Of course, we're going to be seated, erect, or upright in that interior oblique position to make sure that the face is in a true lateral. Head must be a true lateral. We're still going to utilize that IPL line. IPL will be perpendicular to the IR plane, just like we've done for the lateral skull, just like we've done for the lateral facial bone, just like we've done for the lateral nasal bone. Exactly the same. The main difference is we're just going to be centering in a slightly different area, and we must be upright no matter what. lateral sinus x-rays. Based on lab, y'all know where the centering point is on this x-ray?
Isn't it between
Outer campus and the EAM, right?
Right, halfway between the outer campus and the EAM, or to make it simpler, basically if you're on the temple, you're kind of in the right area. Where your temple is.
I think Ms. Bonilla said it was between the outer campus and something.
Yeah, be careful because facial is gonna be slightly different. You're more on the zygoma for the facial. Of course, you're above the EAM before the cranium. It's probably one of the big mistakes. Make sure you know the difference between these laterals, how they change, the variances in the centering points.
So, not outer campus, you said what?
Between, well, it's gonna be on the next slide, between outer
Okay.
campus and EAM. Yeah. By the way, SLC, I do wanna debrief with y'all after class about how the booth went. How the booth went. I saw that some of y'all being some professional vendors out there. I was proud of y'all. Willing and doing.
When it says horizontal to ensure proper extension of the head, does that mean like parallel to the IR or just straight up?
I mean, really, it's just a perpendicular projection. Usually, you say horizontal when you have the patient like in an upright position. It's just a different terminology.
Okay.
All right, so horizontal and perpendicular to the IR. Where are we entering 1 inch posterior to the outer campus, or as y'all have learned in lab, like we just said, basically you're halfway between the outer campus and the EAM. Or if you want to make it even simpler, this is not how it would be worded in the question, by the way, but little, pro strat. If you put your crosshair on the patient's temple, you're in the right spot. The patient's temple. Of course, as I said, guys, collimation, very important. You want to make sure you collimate at least to an 8x10. Otherwise, those sinuses won't pop how we want them to. They won't have that nice quality, that nice definition. If we leave it wide open, like we see some of these texts do, it's going to take away that fine detail that's very necessary to be able to visualize those fluid levels. That's the main reason they're doing this, by the way, once again, to see the fluid levels of those sinus cavities. Also, to make note, and it's probably going to be on the next couple slides, but go ahead and write this down. When it comes to viewing all 4 sinus groups, the upright lateral is the optimal position every single time for visualizing all 4 sinus groups together. Upright lateral is the optimal position for visualizing all 4 sinus groups together.
Ooh.
Excuse me, Mr. Dunn, is it upright lateral?
Sorry?
This upright lateral.
Upright lateral
For
for all 4 sinus groups, yes.
It's back.
Yes, do that again.
I'm about to have a very unkind word with this IT team.
We were gone for 4 days. 4 days.
All this technology in here is not working.
How did you do our presentation?
That's why.
That's
Why?
true.
I don't
We
ask
should
for
do it
much.
today.
You know what, you should send it.
This is messed up.
We're translating to
Oh.
Exactly.
So now
All
we
right,
can-
so
Keep pressing, keep pressing.
something to make note of. Now, this is a more subjective thing here, guys, but something you want to write down. If we're doing a sinus x-ray for a preoperative exam, Merrill's does suggest a 72-inch SID to minimize the magnification and distortion. But for all other normal cases, you're still going to stick with 40. This is only for preoperative measurements. If they're going in for surgery for their sinuses, you want to do 72. Otherwise, you stick with 40. Keyword surgery there, guys. And as I said, Star Bar shows all 4 sinus cavities. This is the best way to see all 4 together. That upright lateral. And you want that nice tight collimation like you see in that picture there. That's all we're interested in. We don't want to see the top of the skull. We don't want to see the face. We just need those 4 sinus cavities on that x-ray. The tighter the collimation, the more beautiful it's going to look.
questions you think it's gonna be about for this test?
How many questions? I want to say it's about 60 questions.
Any, images?
If there's images, it'll be more along the lines of what position is this. There's not gonna be like anatomy images. All right, so evaluation criteria, of course, because it's the star of our show, we do want to see all 4 of those sinus groups in their complete totality. And the sphenoidal sinus will be best demonstrated in this position. Put that in big bold red for you. Sphenoidal sinus will be best demonstrated in this position. And you'll see as we go through the rest of these positions here in a minute, every position will basically isolate a particular sinus and show it in the best way, depending on which position we're utilizing. Of course, air fluid levels if present. If we actually have those fluid levels, you're going to see them. That nice little straight line, just like within the cubitus chest, cubitus abdomen. Of course, no rotation or tilt. So we look at that stella turcica, the orbital roofs, and those mandibular raminae to be nicely superimposed.
How tight is this combination? I know it's 8 by 10, but.
At least 8 by 10 is just what they recommend.
But.
You can go tighter,
Yeah.
but you sort of be careful because you end up clipping, you know, part of those sinuses if you're too heavy with the combination. All right, let's go to our, I don't know why I have animations on that one, no other ones, but here we go, let me get all these up. It's not even moving. Whoops. Whoa, okay, hang on, slow down. Alright. Okay, PA axial, Caldwell, oh for goodness sakes, Caldwell method for the sinuses. Now, this is called Caldwell, it's also called PA axial, but you're gonna notice something in that we actually don't angle our tube on this x-ray. You'll probably remember that from lab, yes? This is one of the only axials that we learned in x-ray, we're actually not angling the tube. Keep that in mind, that often throws people off. As always, when we seat upright, we want that nice erect position. And your book does suggest, although you don't have to do this, that you tilt your bucky down 15 degrees. Do y'all know y'all can do that, by the way, with the buckies, if they tilt? Have y'all seen that?
Not in Thomas Street.
Not every bucky, but a lot of them will allow you to tilt. Now, that's not required. You'll notice in the picture they actually don't have it tilted. They actually put a little pillow on the dude's head, or a sponge, whatever that is, on the top picture. And I personally have never actually tilted the bucky for a Caldwell sinus. What I've always done, and actually it's part of the positioning, is you simply just put the patient's tip of the nose on the IR. And you'll notice for the other Caldwells, what do? We hit the forehead and the nose. But now we're just gonna use the tip of the nose, and that will create the angulation of those sinuses that we need to do a Caldwell of those sinuses. So OML will be perpendicular. We're still utilizing that positioning line. But best pro tip for your Caldwell sinuses is just use the tip of the nose. Don't worry about turning that bucky. Don't worry about putting that sponge. It's gonna overcomplicate it. By the way, just to make mention, guys, another reason you want to make sure you master these sinuses is that when it comes to your capstone in the summer, everyone has to do the full sinus series as part of your capstone. That's a mandatory.
For the first one?
Hmm?
For the first one?
Well, you're gonna be doing both. It's a part 1 and part 2. It's part of part 2.
Part two.
Yeah.
Which is not in the summer, right?
We haven't decided that yet. Depends on the lab situation.
Oh, okay.
Why do you have lab here?
Hmm?
Why do you have lab
It's
here?
about the new lab
Oh.
situation. Depends on how quickly we get the new lab installed. Which that's moving along, guys, by the way.
Awesome.
Moving
So we
along quite well. We're just basically just negotiating between different vendors to get the best price.
how long would it take them to actually construct the room?
They told me 7 to 8 weeks.
That's a lie though, they always lie.
Do they?
Yeah, they only project when they can do
Like,
it
yeah,
faster. Yeah,
it's always, that's a,
yeah.
oh yeah, I can have her.
It's
They're just trying to
like
make you
to
sign.
cut
Once you sign, what you gonna do?
Right. Okay, heart position. Once again, extend the neck to the tip of the nose is on the grid device. When we do that, the OML will be at a 15-degree angle to the horizontal IR. They say you can use that support if needed. Once again, I've never had to use that. I mean, just putting the tip of the patient's nose on the IR, most people are easily able to do that. never an issue. Steer the nasion to the IR, and it'll say there this method's not preferred because it's going to create OID, but once again, in my personal opinion, it's a superior way to do it. It just works better. It doesn't magnify it that much. What they refer to as the optimal way is to actually turn the bucky in that 15-degree angle, but to me that overcomplicates it for yourself personally. I've never had any issues, and the tip of the nose technique works quite well.
Said they had fixed it already? Said they fixed it already?
Fixed it.
Whatever the problem was.
They haven't told me to fix it. Someone was obviously messing with it. Maybe get the picture up here now. I don't know why it's saying SmartCast over there. Someone was trying to do SmartCast. You probably, if you are close to the buttons over there, you can probably change the input. It'll bring up the picture. They just don't look on the input.
Am I good?
Do I want to do it?
No, it's okay.
Oh, I mean, if you want to try. Oh,
Oh, no,
the
I'm
buttons
not
are on the
sure.
other side like Carla.
There's some buttons.
You can try.
What do you want me to do?
You want to change the input, I believe.
That's
Not the
all.
volume. You can just turn it off. As she's figuring that out, let's go to part 3 here, guys. As we talk about the central ray. Get all these little bullet points up. So, central ray, despite this being called axial, make note this is a horizontal perpendicular beam. We're achieving the axial nature by positioning the patient's head in a different way. Yeah, just need to choose the input.
Okay, so HDMI
One of the
one.
HDMIs.
One more.
Is it 1 or 2?
One.
Should be one. There you go. All right, a little bit easier for y'all now. Okay, perfect. Now, for the central ray, it will exit the nasion. That's going to have a 15-degree relationship between the CR and the OML, because the OML is basically placed in a 15-degree angulation. And we still want that nice tight collimation of no more than 8/10 to make sure that we are seeing those sinuses in the best way possible. The bigger that collimation, like the wider it is, the wider it's going to kind of fade away. We're not going to see them very well. Make sure you know that 15-degree relationship between the CR and the OML. It's basically how we're kind of like cheating to create an axial view. Does anybody know why we do that? Like, why not just do like a regular pulse with a regular angle? Anybody know?
For shortening. No.
Think about what we're looking at on these x-rays.
YD.
It is to do with fluid levels. I think someone just said that. So even though it's a slight change, whenever I put my forehead and nose on the IR, what am I doing? I'm tilting my head down slightly. So how's the fluid going to go?
fluid is going down.
It's going to start going forward. But if I do the tip of my nose, I'm in the perfect
It's gonna
upright,
stay.
and it sits at an even level. Like anything like water in a tube, how it shifts around, it would have a nice level appearance. That's why we do that. I don't think your book tells you that, but fun fact there.
Bonus question.
So, it's 15 degrees, but we're not tilting the tube, we're just not.
We're basically just tilting the patient's head in a different manner to simulate an axial. We either tilt the bucky or we just, as you see on the bottom, we put the patient's tip of the nose on there. The main point is we want to keep that head in that perfect upright level position, so we see those fluid levels evenly.
Yeah, it's kind of confusing though, cause it's like it's saying you wanna tilt it, like you're saying you wanna like make a movement, but it's actually perfectly upright, you know what I mean?
So is
Yeah.
it tilting the head?
I don't know what they were thinking in the world of X-ray, because technically axial is always referred to a tube being angled. It's the only one that we do not angle the tube. It's called axial. It's a little confusing, but I don't know. Maybe they were Maybe they were having a bad day that day, and they were naming this stuff. But you know what, just call it axial. Just do make note of that, guys. Do make note, when we're talking about the other two axials, they will have that angulation of the tube. This is the only one in X-ray that you're gonna learn that is not actually angling the tube. All right, so of course, as I said, each position is going to show different sizes in their totality. When we look at the axial, well, obviously, look at how close that frontal bone is to the IR. We're going to see those frontal sizes really good, unlike this screen, which you can't see very good. We're going to see those frontal sizes really good with that frontonasal suture as well. We're also going to see specifically the anterior ethmoid air cells. And also, just barely, even though we can't see it well, we're going to see the sphenoid sinuses through the nasal fossa, or basically your nose holes, put it in layman's terms. Doesn't it sound very nice, do your nose holes? You'll see your sphenoid sinus, just a little bit. Then, of course, because this is Caldwell, what's the main characteristic of a Caldwell? Petrous pyramids are where?
Lower third.
Lower third of the orbits. But primarily, of all the things we're looking at on this X-ray, we're looking at frontal sinuses and anterior ethmoid sinuses, or air cells, as they're called sometimes.
Why are you, what's the reason you want to say interior ethmoid air cells?
Why do we say anterior?
And not just say the regular?
Because think
ethmoid?
about, like, if you remember from the anatomy how the ethmoid's gonna go quite a ways back. You have like the anterior, you have the middle, and the posterior ones.
Yeah.
Well, when I'm facing the IR, what's closest to the IR? The anterior. So therefore, even though they're kind of all superimposed, that's the main one you're seeing. So
Okay.
closest to the IR. Sphenoid, so, I'm sorry I don't have a laser, but you see the nose, like the fossae of the nose?
So it's near the
See that dark
perpendicular
part?
plate?
For here?
You don't see them very well, but just through the, say the nose holes.
So it's near the perpendicular plate right there.
On each side of the septum, yes, each side of the septum. Yeah, you don't see them very well, but they are there. Yeah, yeah, that's the sphenoid.
I like this, they go all the way up.
Tell you what, my sphenoid and ethmoid sinuses are all stopped up. Yeah, Wichita.
Wait, how do you say that?
Wichita? Not Wichita, if you're saying that way, Wichita.
Well, where are Wichita?
All right, guys, evaluation criteria. What do we want to make sure that we see for this to be an optimized image? Well, of course, frontal sinuses, because we are seeing them very well, they need to be above the frontonasal suture. Otherwise, we do not have the head positioned correctly. For those ethmoid air cells or sinuses, they need to be above the petrous ridges. Remember, those are located at the tear duct area you see there. No rotation or tilt, just like every other position. And we must have those petrous ridges where, guys? The lower third of the orbit. I know I'm like a repeating record when I say that, but you'd be amazed how many people still miss that question on these Caldwells. They get the waters and the Caldwells mixed up on the petrous ridges. Lower 1/3 of the orbits. And of course, sinuses are going to always throw that extra one in there that you must see those air fluid levels if they're present.
Oh, yeah, that's right, Mr. Donahue, for the, I paid the $30 for the parking and everything, but my badge doesn't, work, so I haven't
You
been
give
able
us
to.
security then.
I already did. Miss, no, Miss Vance took it already there and they
Still no?
no, they need a refund on money. Cause just like they're asking for it.
Yeah, this security person's not the friendliest.
No, she gave me a I walk in there,
She asked me a lot of questions about it. She gave me another one.
We'll get on it, guys. I'm sorry. That's very inconvenient. I'm sorry.
And then right now when I try to get in, I couldn't, I had to knock on the door.
I wish we just had to do it this way. Is that?
She cool, but she don't be on. I
Alright guys, let's move on to the waters. Of course, we are still having the patient see is it correct. Now for the waters, this is gonna be done exactly like the waters we've learned before. No difference at all. We're just gonna accommodate a little bit tighter because we're only looking at the sinuses. So of course we rest the chin, tip of the chin on the vertical grid device. Big point there, I probably should put that in big bold red because it's something they love to ask on water sciences. When we hyperextend the neck, we're gonna place the OML at a 37-degree angle. OML is placed at a 37-degree angle. Which line are we using? That'll be the MML. Is be perpendicular to the IR. Does anybody want to guess what sciences we're really going to be looking at well on this one?
Maxillary.
Maxillary, very good. Maxillary.
Which one?
On the water.
I don't know. I accidentally keep doing it.
Or also make sure you know that other name because you're not always going to see them together. It's a parieto-acanthial projection. Parieto-acanthial projection.
Since the collimation for this one and the facial bones similar.
Pretty similar. I would say you go a little tighter on this one because like you don't need zygoma. You can go super pro-tech mode on this if you want to. But typically at least about 8 by 10, like people say, is what they recommend for a minimum.
And you said the maxillary sinus?
Maxillary sinuses are going to be our star of our show, which we're going to find out here in a minute. By the way, I haven't forgotten about y'all's mannequins in the back, guys. I'm still going to announce that. Just wait until after this test because I'm going to apply the points to this test. I feel like this will be a little bit of a tougher test than the last one. Y'all just did too well in the last one, so.
Yeah.
I don't think so.
Is that a pickle?
Is it a color?
Did you say a pickle?
Yeah, there's like green something on the.
Are you colorblind?
Yeah.
Hey,
You're looking at the one on the right.
wrap this thing
Oh,
up.
it's a
I'll see you
coat.
there.
Empty and full.
And then we have your test and Peoria test.
All right, so make note because we are upright, we're still utilizing a horizontal perpendicular beam, and it's going to be exiting the acanthion. As I just said, at minimum you want an 8 by 10 collimation field. Go tighter if you can, just to make those sinuses pop even more, look even better. Nothing's changed there as far as waters goes. And of course, when we look at our evaluation criteria, guys, what happens to those feature switches on the waters? Where should they be?
They're down below.
Below the what?
maxillaries.
Below the maxillaries. Below the maxillaries.
So that's when you see maxillary sinuses? Is that what you said?
Hmm?
When are the incoming juniors coming in?
So they come to their onboarding with HR next month, around 15th, like mid-May, something like that.
We won't be here.
Y'all won't be here, but yeah, that's coming around the corner pretty quick.
Have y'all decided if we're gonna go ahead and do 3 days in the summer?
Of course, that's what we'll be discussing so immediately following graduation, we have a big faculty meeting where we basically map out the following year, so we'll let y'all know ASAP. Most likely though, yes, to answer your question. It's looking that way. Unless we get some pushback.
What classes will we have?
You have evaluation of radiographs, you have your first review course with me, and then you have your capstone practice labs.
During the summer? Okay.
Does that take into consideration Levy's, suggestion where we split it half and shop half?
We're gonna try to make the travel as little as possible. We're working on all that. We do take your critiques very seriously, we really do. Okay, guys, so like I said, or like y'all said rather, maxillary sinuses are now the star of the show on the waters. We also need to see those Petrus pyramids below or inferior to the maxillary floor. And the frontal and F1s will become what we call a distorted disposition, the way we're turning the head up. Now, if we don't have that neck up enough, if we don't have them resting on that chin correctly, the Petrus ridges will be over the inferior portions of the maxillary sinuses, and that's a big no-no because we need to see them in full detail. We need to see those maxillary sinuses fully to get a good evaluation of them. Maxillaries are often very commonly some of the most infected sinuses when it comes to fluid levels. So you can't cover up any part of it. Now, if you overextend the neck, or if you bring the chin up way too far, the maxillary sinuses become too foreshortened. You're not going to get that full, nice pyramid shape that we look for, a triangular shape. So those are two really good questions there in those blue boxes. We're talking about critiquing. I'd write those down. Really good points.
You said if the head's too far back.
Like if you overextend the neck, like bring the chin up too much, the maxillaries become foreshortened. Thank God this still wasn't happening during the speeches though.
Shit, that would happen.
Because last year they had all kinds of issues with that projector. I was thankful this year.
Well, you brought it to us then.
I guess so.
You didn't drink coffee that day?
I did, but it wasn't very good. That hotel coffee was just like
Was weak.
brown water.
It takes like 6 cups of that stuff
There's like no caffeine in that coffee.
at all.
Pancakes were good though.
Yeah,
Thought about
I
drinking
didn't know,
that.
I didn't know that me and you were in the same, like,
You were like 2 doors down from me. I was like, oh God.
I know if I would've known that, I
discovered
would've
me.
been like.
She discovered
I was being so,
Jamaica.
I was being so
And you
incognito on
opened
this
our
trip,
door.
and then I saw you come out. I was like, oh.
You were like, oh, sorry, sir.
No, I got Reagan good.
Even senior.
I got Reagan good though. Reagan came and knocked on our door. I said, "Who is that knocking at the door?" And then the peephole, you see Reagan's feet off.
Did you guys go out to the ball or lay that
You're Chipotle.
I gotta say, I was happy with my room though, because it was supposed to be a king bed, but they made a mistake. It was queens, but it was a humongous room. It was like a little suite, so I was like, it was really spacious, a humongous room. I was like, okay.
Full size. And you were in there by yourself?
Yeah. So you're not gonna switch beds in the middle of the night. One wasn't feeling good, so.
Me.
My room, the thermostat didn't work very good.
Huh?
My room, the thermostat didn't work very good.
You know what it did?
Did you
Because
use
she took all the air.
Did you use
I was
The one
thinking,
from the wall?
yeah,
I did.
either was too cold.
Ours was too cold.
I could never get in the zone. I just could not get in the temperature zone.
So she left Friday when you got there and
Put it at
she put it at 65.
Yeah.
Oh, did?
Good grief. By the way, I do gotta commend you guys. Like seriously, thank y'all for being on such good behavior. Like it's probably the first year I haven't gotten any kind of complaints about a class, like being too noisy or
See,
rowdy.
it's that senior class.
Were we?
But the seniors are good too. Like everyone, y'all, I really do appreciate that. Y'all were all.
He's
Y'all
very
represented,
surprised.
hey, y'all represented the school very well, and I appreciate that. Really do.
Did anybody put anything on your tab?
Huh?
Did anybody put anything on your tab?
They better know I have. Check that receipt. Better check that receipt.
I said, put it on Donahue's tab. Donahue, John and Donahue, room 4 or something.
Social Security 642.
Did I tell you about that one? I'm thinking Friday night, man.
All right, guys.
Destroy the room.
Evaluation criteria, of course, because we're seeing the maxillary sinuses in such a good view, we have to see all the maxillary sinuses left and right. We also want to make sure that OML is in proper position. How do we do that? Well, of course, Peaches preaching. Peaches pyramids immediately appear to the floor of the maxillary sinuses. That song gets so stuck in your head, by the way.
Thanks.
Symmetric orbits and maxillary sinuses and MSP aligned correctly, long axis of the colonnade fill. And of course, those air fluid levels, if present, as with all our sinus X-rays.
We can't do our speech today.
That's why I didn't even talk today. I tell you what, like I was so stressed out for these speeches. Like my adrenaline levels were so high. Like as soon as we were done, like I just had like I just crashed. The adrenaline just left my body. I was just like hurt. My body was just like hurting.
You look like you came from a spa when you like walked out. I think on Saturday. Like you just look so chill, so calm.
I was finally able to relax. Yeah. Oof. But it was worth. The opportunity was worth.
What was in your goodie bag?
The goodie bag, so they gave us you got a t-shirt, you got a thank you card, and we got this really pretty certificate with your speech title on it.
That's
It
cool.
was really nice. Something to frame, you know.
Nice.
Put it here.
Sick.
Frame it here. Somewhere in the top.
Put it here?
Yeah.
I should, huh?
There.
There's a nice spot there, yeah. I'm gonna print out a bunch of y'all's pictures. We can put some of y'all's pictures on the board, because I don't have much of you guys on this bulletin board over here. I won't print out a bunch of your TSRT pictures and put them up there.
I've got my Polaroid and I bring it pretty much everywhere. I just don't have batteries.
I mean, yeah, y'all need to take more pictures. You know, your yearbook, which is coming around the corner, it says "good as you make it out to be" with the pictures. So I mean, go nuts. Get all those little moments. Everyone can play a part in that. Okay. Good Lord, this project. This.
I didn't know that Alza went to that
Yeah, she's actually getting her bachelor's in there in like 2 weeks. Finishing up in 2 weeks. It's all online. Really great program, by the way. Really
MSU?
great program.
MSU's bachelor's?
So she has to drive up there again.
No, you don't have to go to the graduation. It's optional. It's really far. I don't know if she's going to or not, but I wouldn't.
He's like, I didn't.
They have 6 mandatory days out of the year, I think.
That's for
That's for the
masters.
masters,
Oh.
which I highly recommend as well. Really great program.
Where'd you
Okay.
get your master's in?
Huh? Yes.
What did you get in?
Where to get in radiologic science education.
Okay.
You got it from there?
Really great program. I can't commend it enough. It's really, really great. I love that school.
Would it be beneficial to just do that, like get the master's, but not really do RA? Like,
All right, I'm gonna tell you about RA. So, hang on, what time is it? Let me tell you about RA. So RA is a field of radiology that has just not taken off like they hoped. So if you don't know what an RA is, it's a radiologist assistant. It's basically the practitioner side of our career field. It's going to be like a rad practitioner instead of a nurse practitioner. And they had a lot of hopes for it when it was created. It was just coming into fruition when I was getting my master's, getting more popular. And the unfortunate thing is it never quite took off like they hoped, and no one's really hiring people for that position. So while it's a cool opportunity and a cool career path to take, it's really hard to find a job in. Like honestly, the only place I know that you can use them is Texas Children's. And even then it's hard, there's like 2 of them. There's like 30 radiologists that work there. It's just, it's still it's infancy stages, it's just not caught on yet. So I would personally, unless you're just really bored, hold off on that until it picks up more steam to see if it's actually gonna be worth it. You wouldn't want to throw your money away and not be able to get a job. Whereas getting a master's, of course, in admin or education, well, I mean, you can do anything with that. So that's always worth it.
For a PA, wouldn't a PA be better than an RA? Because you have more of an opportunity to
Currently,
get-
yes.
Yeah.
Yes.
As a PA. Yeah, I would recommend.
And then Midwestern's also about to get, they have a doctoral program that they're getting approved for Rad Techs as well. It'll be a Rad Tech doctorate degree. They're trying to get approved. I didn't want to wait anymore, so I did my mental health, but that's more my niche anyway, so, you know, I love that psychology stuff. Well, it appears that this decided to die, so go ahead and take a break while I restart the computer, guys. And we'll wrap up the rest of this. Go ahead and take 10 minutes. Come back at 9:06. We do not have much further to go. Yeah.
Do we do this for lab? Right?
Now, this is going to be done exactly the same way as the ones we just looked at. There's just one difference. We're opening the patient's mouth. That's really the only change that's on this x-ray. So they're still upright, still chin on the grid, still 37 degrees OML. only simply opening the mouth while holding the position to get a better look at the sphenoid sinus. As we'll see here in the next couple of slides. This is done to get a better look at the sphenoid sinus in particular. So the parieto-acanthial projection was the open mouth Waters method. Sometimes also called a modified or transoral Waters.
Is it gonna say open mouth though?
It would have to. You wouldn't just be able to say parieto-acanthial.
Okay, just
That
to
can
make sure.
apply to both.
So everything else is the same except for them open mouth.
It's the only change. Everything's exactly the same.
And you said the other name was modified, transoral, and just open mouth, nothing else?
Yes. So we'll go a little faster here, make sure we get through all this. So guys, central ray, like I said, just copy and paste everything from your previous Waters. Horizontal, exomeacanthion, that has not changed. Still a minimum of 8x10 collimation. As far as structure shown, we can still see the maxillaries. We're just going to add to that we can see the sphenoid sinuses projected through the open mouth. We still see the maxillaries, but we can see the sphenoid sinuses projected through the open mouth.
So on this one, everything is the same. And it's also known as modified transoral.
So this one, the sphenoid sinuses are stars?
Sphenoid and maxillary. Because remember, it's still a water, so it's still the max. I know.
The system says
Did you do that?
y'all.
I did that.
Oh, okay.
Oh,
It's like-
Oh, staring at him
all
like-
right. It just fully gave up.
I don't think he did that.
Oh, and I have to
Give
talk to you
mind
about one of the
over
vendors, like the super tech guy. He was really weird.
Michelle, let me get over
It
it.
really is.
Who?
They got some cool stuff.
Yeah, he was kind of weird.
He started talking about some stuff that was like,
stupid and not mine.
Inappropriate?
yes,
Really?
yes. So like,
To you?
yes.
You always been
Dude,
bad.
Cody was there. He could attest. I didn't
Yeah,
start
he
this in
started
any way. He
talking.
Okay,
started.
guys, so I'm
And
gonna
then
keep
I
talking.
left.
We'll keep talking. So
Cody was like, he's
I'll
not
make sure we
talking.
finish this.
Go on.
But you can let me know after class, Jay. I'm curious.
We're all
For
curious.
the open mouth guys, when it comes to evaluation criteria, everything's the exact same as a Waters. You're right, it's the exact same as a Waters. The only difference is we need to see sphenoid sinuses projected through the open mouth. That's the only change. Everything else is the exact same eval criteria.
He was the only super tech guy there. So I'm sure if like, people walked around, y'all met him, he would off.
Yeah, I've talked to him. Hello. Should I pause this? Go waste of our story.
Last position for the sciences guys is going to be the SMV position. We are still upright. We're just going to be in that SMV position where we hyperextend that neck and rest the vertex of the head on our grid. And when we do that, this is the IOML parallel to the IR while also being perpendicular to the floor. IOML is parallel to the IR while also being perpendicular to the floor. Is all the same as a regular Waters. So you're just seeing sphenoids.
What does SAP stand for again?
Submental vertex.
Nice.
Alright, so this looks very familiar. It should look very familiar because it's really just the exact same SMV we've been learning. We're just basically collimating down to the sciences, guys. Considering just slightly differently, we're gonna have a horizontal perpendicular beam to the IOML. It's gonna enter 3/4 of an inch anterior to the level of the EA
That
elms.
is so extra.
So extra.
3/4 of an inch.
I agree, that is a bit extra. But that's what they want us to know. So collimation again, guys, at minimum 8 by 10. We're only interested in the sinuses, not that entire skull. I do make note of that central rate entrance that it is slightly different than the other SMBs we've learned. It's for your sinuses.
SMB is just for the mandible and the sinuses.
Well, we do it for the skull as well. Now we do it for the cranial floor, the skull. You didn't do it in lab, but it's one of the positions that we learn for skull. I believe you're only doing the SMV for sinuses in lab. All right, very easy as far as structures go, guys. We're only interested in sinuses, and those specifically are going to be the sphenoid and the ethmoid sinuses. Sphenoid and ethmoid sinuses.
What other anatomy is like clearly visualized here?
Well, really, the condyloid processes of the mandible you can see really well. You can see basically the hard palate and the septum, most of the teeth there. You can see the foramen magnum, you can see the pubis ridges. But that's mostly if you're going to be doing like a skull x-ray, you're going to focus more on that stuff. When it comes to the sinuses, we're just really only interested in those sinus cavities at this point.
Would you also use this projection for I forgot the
Like zygomatic?
for foreign bodies, like if let's say if they got shrapnel in the face and you wanted to see like how deep it
Possibly,
was.
yes. Depending on, depending on how deep it is, they may do that. Absolutely. If there's like a BB in the face or something.
Can't you do a lateral
That's
front?
funny.
Is there a reason
like
why you can see
Oh.
more on their right side than on their left? Like how you see how like the maxillary sinus you can like clearly see it there, but on this side you can't really see it that well.
That's because there's fluid in there.
Oh, okay.
Good eye, by the way.
So it's fluid in the
Yes.
sinus?
Yes,
That's why it's
in the,
clear?
in the left maxillary. It'll usually look whited out like that when there's fluid.
But their whole side is kind of grayed out on that side. Like over.
All right, and then the evaluation criteria, stars of our show again, sphenoid and ethmoid sinuses. We want to make sure there's no tilt of the skull, otherwise we won't see those sinuses manifest correctly. Big one in red, that third to last point, this is with all of our SMVs, mandibular condyles, or the condyloid processes as they're also called, are going to be anterior to those petrous pyramids. Anterior to petrous pyramids. And of course, air fluid levels, if they're present. We'll see that as well.
Should we also be able to, or rather, have it possible to visualize the foramina and the sphenoid?
If you're doing a skull, yes, that'd be more important, but for this one, no. Because on the skull, you're looking at the cranial floor, which we would be able to see that more clearly, but not a concern on a sinus SMV.
Okay, so it's not one of the evaluation.
No. All right. So just a couple of review questions here, guys. Then we're going to wrap up with orbits, and that'll be the end of this chapter. Which sinuses are best demonstrated on the Paredio, Canfield, or Waters method? Maxillaries. Which sinuses are best demonstrated on the PA axial Caldwell method?
Sphenoid? No, frontal?
PA axial Caldwell. Through the frontal. Which projection demonstrates all four sinuses? Lateral. And make note, once again, it's not worded in this question, but most commonly, and where they'll get tricky on you on the registry, they'll put a lateral in there, but they'll also put an upright lateral. You wanna make sure you're paying attention, and when you see both, you're always gonna select the what?
Upright.
If you only see lateral, you'd select lateral. Does that make sense?
Don't be like a which projection best demonstrates.
I'll add those little variances. Which sizes are indicated by the arrow?
Frontal.
That's the frontal, very good. Which sizes are demonstrated in this projection?
Oh, that's
Two and three, correct. Frontal and the F1. And what position is that, by the way?
Facial waters? Facial
Waters.
Oh,
It's the Caldwell. How can you tell it's a Caldwell, not
oh
a
yeah,
Waters?
the Petrus
Those
regions.
Petrus ridges being the lower 1/3 of the orbits. Also, if you look closely, the next thing is kind of cut off too. And this projection is a modification to demonstrate what?
D.
We gotta identify what it is first. This will be the open mouth waters. And that's done to demonstrate sphenoid. Sphenoid, very good. All right, let's look at our orbits, guys. Not much more to go here, and orbits are not nearly as important anymore. There are a few things they want you to know for the registry that we're gonna hit. They've actually cut this down quite a bit, just like the screen just got cut.
Straight foot.
Completely.
There we go. And the ones that we're gonna learn are the lateral, the PA axial, and we're still gonna do a waters for the orbits as well. Because waters actually shows those blowout fractures we talked about really well. Now, why do we do orbits? Most of the time these days, we do orbits if there's some kind of foreign body near the eye. Mostly for foreign bodies. Also, if they want to screen for metallic objects for an MRI, if they have some kind of fear there might be something metal near the eye. Of course, that'd be a bad news for the patient. They wouldn't have an MRI with that in their orbit area. And of course, if there's trauma to the orbits, like there's been a punch to the face, a wreck, they're afraid of that blowout fracture, that tripod fracture. They may still do these, but most of the time, it's just a straight CT exam. If there's any kind of danger near the orbits. They barely do these in X-ray anymore. So when it comes to positioning for a lateral orbits, that can be upright or recumbent. Once again, upright, always the best way to do it. When we position for this, you're gonna have the outer canthus of the affected eye centered to the IR. So you have the side down, basically. The outer canthus touching the IR. You want the IPL perpendicular, and basically you're just gonna put them in a regular lateral, honestly. It's gonna sound complicated, but just basically put them in a regular lateral, just like a skull. Just centering more so where that IPL line is. You see on the picture there. Kind of lining it up with the IPLs. Put it on that rim, the orbit, as we'll see here in a second. IOML perpendicular to the front IR edge. Very small area we're working with there. This is done to look at those orbital realms, by the way, this X-ray, orbital realms. So perpendicular through the outer canthus. What do we want to see? Entire orbits as best as possible, not the prettiest X-ray, which would be nice if you could see what I'm talking about. No rotation, we want the orbital roots to be superimposed, and you want nice, tight collimation. And when it comes to collimation of all the facial bones and sciences and everything we've learned about, tight collimation is going to matter the most for orbits, because they're actually very hard to see on the X-rays. Very, very difficult. So you want super tight collimation. It doesn't give you a minimum, but the tighter, the better. Central ray, as I said, once again, is through the outer canthus. Come on, we got a couple more slides. You can do it. So again, one of the main reasons they would do a lateral of the orbits like this is if there's some kind of foreign body near the eye. They need to see if it's more anterior or posterior within the orbital area.
You know, after all their checking and IT work, did they ever just like take out the cord and blow on it to the back end?
They actually replaced the entire cord, but we think it's actually like a driver issue on the computer that's causing the problem.
That's a entirely better.
Where does the CR go?
CR goes through the outer campus.
From
Just
one
basically,
outer campus to
yeah,
another?
from one to the other. So the side that's up, you're gonna put your target right on the outer campus.
And you mark the side that's down?
Mark the side that's down. All right, so for the PA axial guys, done almost just like a Caldwell, basically. It's a PA axial orbit. It can be upright or recumbent on this X-ray. You're gonna use the OML, place the OML perpendicular. OML perpendicular for a PA axial orbit. Let's make our main points here, guys. Let's try to reboot.
You said OML perpendicular?
OML is perpendicular to the IR, is in your book too. Head, so the forehead and nose are touching just like the Caldwells you've learned before. Forehead and nose are both touching the IR. We are. It's coming up next. So, different from the sizes we just learned. It's kind of back to those other Caldwells we already talked about. In fact, we're basically doing it the exact same way, we're just commenting down the orbits.
It's a first.
That was nice.
Mm-hmm, it sure was.
No, it was nice.
Mm-hmm, yeah, it was.
I helped. Same time.
No, I think mine is on. You heard it?
I heard
You heard it, right? I didn't hear it.
Hello.
I can feel
The
it. It's
room
like
said
broken.
like hello, and then whose ever name got the room when you first walked in on the TV.
What's the setting?
What's that?
What's the setting for this?
Just stay away from those machines.
Isn't it still at the?
Perpendicular to the plane of the island.
Oh, so
Is
sweet.
it the OML?
No, what's the center over here? Like,
You get
because it's
Alright,
PA, right?
guys.
on Sunday?
Moving on for the axial, your central ray. Your central ray location for a PA axial orbits is through the center of the orbits, basically in between both. So really it's kind of at the nasion. Yeah. It says for the orbits, it's gonna be through the center of the orbits, even though you're technically on the nasion.
Exiting Nasia?
So don't write nasion unless you're right through the center of the orbits, that's what the curriculum says, but if you're kind of wanting to reference what I'm talking about, you're right
Okay.
here for the nasion.
But it would be exiting the center of the orbits?
Yeah. Caudad angulation of 30 degrees. There it is. Oh, there it was. 30-degree caudad angulation. 30 degrees. We have a sharp angulation on this one. And the reason we add a little bit sharper angulation on this one is to distort the orbits and make them larger. It's just PA axial.
You said to distort the orbits to make them larger?
Correct. As far as what we look at for eval criteria, guys, we want the entire orbit, or orbits plural. We also want the petrous ridges below the orbits, so we can see the entire orbit without restriction. Petrous ridges below the orbit, so we can see the entire orbit without restriction. And of course, close collimation, just the orbits. I'm sorry, guys. I know this is frustrating. Hmm? It's in your book too, though. This is directly from the book. You have textbooks. You say you want the PowerPoint. You have the PowerPoint. It's your textbook.
It's so PowerPoint plus too much extra stuff,
Yeah.
too much extra information.
We like the color change. When you put it in red, it really helps us out.
Yeah.
Well, this section has no red, by the way. It's
Well, she.
orbits are barely commented on.
Jay's like, I tried.
Alright, so
I'm really
for
trying.
orbits, guys, make a note when we talk about the waters position for an orbits, it is a modified waters. That's how they designate it, separate from the other waters X-rays. Parieto-Canfield modified waters for orbits. Parieto-Canfield modified waters for orbits.
Is it modified for the open road? Or is it just?
It's also modified, yes.
Everything's modified.
But for orbits, it's only called modified. Whereas the science one had multiple names.
Is there a point of this? So just stop recording.
So we're gonna center, once again, at the center of the orbits. Chins on the IR, just like the waters. But we're gonna have the flexion of the neck form a 50-degree angle. That's the modified portion. Flexion of the neck is at a 50-degree angle. We're gonna write that part down. 50-degree angle.
So,
What now?
We're not placing the
I
envelope.
haven't touched my
directly
book
on
since
there, no.
Wednesday.
More so like.
Enjoy the take
you're
a
just
picture.
placing the
Picture,
chin
hurry, take
on the
a
IR
I
then?
took it.
That's what
No,
gives you the
I-
angle?
Oh, I thought you were ready for it to come.
Yeah, like
This
down here.
portion of the chin.
Where your mat,
I'm waiting
where
for
your
it to
mat
change
sits
this
like
last
that,
so I can take it.
so that you can like, it pulls your head forward.
That doesn't look like what you do. I know, it looks like the chin.
It looks very similar, but the way it should look is the bottom of your chin, actually on there.
Also like near your throat area.
And it would. It's probably why they don't, I mean, I've never even done just one of these. But these all just go to CT now. It's a very old position.
So you know how you said that they have that new X-ray machine where you just put the patient in there and it takes like the 360 or whatever? Would it work for these or?
It's
did-
just for mandible and teeth.
Oh, okay.
Like, talk about the pan.
No.
Anorex.
No.
He was talking about how
The EOS.
in
Yeah, that one.
pediatric
The EOS machine.
Texas children, only
Oh,
Texas
the
children
one
has
with
it.
EOS.
Yeah.
EOS. It could, yes, in theory.
So
So it's
wait.
used mostly for spinal x-rays right now,
So it just functions through angulation then, or like?
basically. Yeah. Alright guys, last bit here. Central ray perpendicular to the mid-orbits. What do we need to see? Well, anything with an orbits x-ray, we want the entire orbits, plural, the left and the right. And we want to make sure, which is why we are adjusting the head angle a little bit, we want to make sure the petrous ridges are below the orbital floors. So we basically want those orbital areas empty. So we can make sure there's no foreign bodies, make sure there's no blowout fractures, tripod fractures, things like that. In that close collimation.
When you say below
Below the orbital areas, like the orbital floors. So the bottom of your orbits, you just want to make sure they're below that. Because if they're above, it should be, but you're still gonna make that comment. Water should automatically do that, yes.
Below the maxillary.
Yes. A little bit redundant, but yes. Don't panic too much about these orbit x-rays. Like I said, barely done, if at all anymore. Obscure. I predict this will be out of the quicker than next year.
For signs that will come out.
No.
There is a video, right?
Whew, it's exhausting, this stuff doesn't work like it's supposed to.
Look at it.
Alright, that's the end of the chapter, guys, so.
Did you show the one after this one last week?
What? It's just that one.
Oh, oh my God.
The end.
Mr. Donahue, I have a question.
Yes.